Hi, this is Pat Iyer with Legal Nurse Podcast. We're going to take you into the buzzing, alarming, frenetic atmosphere of the ICU for this podcast as you get a chance to meet Amy McCutcheon, who is both a legal nurse consultant and a nurse with very recent critical care experience. Amy and I became known to each other when she attended our legal nurse consulting conference and then joined the LNC Success Connection membership program that I run. And I have enjoyed getting to know Amy's perspective on the world, and I'm sure you will enjoy that as well. Amy, welcome to the show.
Thank you so much, Pat. I'm really excited to share with you and your listeners just some insights about the intensive care unit that you might not know. For example, did you know that most critical care nurses are actually very experienced hospice nurses as well?
I think that's interesting.
It's a bit of a misconception. I think people think that we just keep people alive no matter what. And while that is a big aspect of it, we do spend a lot of our time caring for the actively dying patient with comfort measures and whatnot. So, yeah. It's a very varied environment. You never know what you're going to get.
Mm-hmm. You know, I think the intensive care unit is a bit mysterious for people, particularly med-surg nurses like myself who have not spent much time in there. But my husband ended up having triple bypass surgery done about 10 years ago and was in Johns Hopkins ICU. And I remember his stretcher. I was allowed to stand in the waiting room of the hallway when they were bringing him out of the recovery room and taking him down to the hall of ICU. And they knew I would be in the waiting room, so they slowed down. It was a majestic procession of two people on each side of the bed and one person pushing, and he had a ventilator in, and his face was all ballooned up from the fluids that he got.
Right.
And they allowed me to see him and pat him on the shoulder before moving him into the ICU unit. And what I remember the most about that, Amy, is that he was kind of restless, and I went into nurse mode when I was allowed in the room, and I was touching him and talking to him. And there was a portion of his brain that was hearing it because he settled down when he heard my voice. And when I wasn't talking, he was back in his still, coming out of the anesthesia fog. There's a lot of responsibilities for nurses who work in critical care units, and I just got pulled back into one with that story. Tell us about the atmosphere, in addition to dealing with a lot of dying patients. What is it like to work in a critical care unit for the staff who are on duty day after day?
Day after day, I mean, it's probably one of, like you mentioned, one of the most challenging areas of nursing for our mental well-being. It's very, obviously it's intense, it's high paced, it can be chaotic sometimes, but it's like what we refer to it as an organized chaos. Everybody has a place and a responsibility, but I think as a nurse, I started in the intensive care unit right out of nursing school. And so that was extremely intimidating. I was very, very nervous. I was very scared. I was going to kill somebody. And luckily, you have preceptors and teachers and mentors and everything, but it's, as a new nurse, I was afraid that if I did one little thing wrong, I was going to really hurt someone. What you gain through working through an intense unit like that is that luckily it would have to be a pretty significant thing. And I think we're going to talk about that in a little while, about what some of the liabilities are in the critical care unit. But there's a lot of camaraderie amongst the staff. If you're in a good unit, which I have always been in a good unit, I've been very blessed. It's a tremendous amount of teamwork. That was the one thing I think that I took away from me as a new grad coming off orientation in the intensive care unit is knowing that I wasn't by myself. You know, it was okay for me to not know something, but of course I have to ask, you know, and that's the confidence that you have to build in yourself, is that you're not supposed to know everything. You have to use your resources. And so the ICU unit that I worked in, we had our providers right there in the unit with us. Actually, when I was a new grad, I was in a small rural hospital. We did not have providers in the unit. And that was extremely frustrating when, you know, you need something now. But the bigger hospitals, the more advanced intensive care units have, you know, you have either cardiologists or pulmonologists, or not, scratch that. Pulmonologists or anesthesiologists are typically your ICU doctors, and on call during the day and at night. Well, then we often had a PA or an NP as well, and then at night the same thing. And so it's really nice to have a patient who may be going sideways or downhill and being able to just either run into their office or pick up the phone and get what you need. But we rely a lot on each other. It's a very, very interwoven staffing situation. I mean, you've got respiratory therapists on staff in the ICU, you've got physical therapists, you know, we got pharmacists who sit in our ICU. So it's just a very different atmosphere from working on a regular floor where you don't have as much opportunity for teamwork, because everybody is really, you've got so many patients that, you know, you're just spread kind of thin. So.
And in large sense, I think spread invisibly, because working as I did on long corridor med-surg units that were designed in a different era, you would be in a room and could be getting into trouble and nobody around you would know that you needed help. The ICUs that I have been in have been much more of an open plan or a circular or a rectangular plan, where you're not walking hundreds of feet to find somebody to help you. You're more visually connected, or at least more auditorially connected.
I was going to say, we've always been able to just yell, you know, if something happens, you just holler and somebody will hear something and come running. So I agree. Mm-hmm. It's a very different, very different design than a regular unit.
And that design in that environment, though, also comes with it a tremendous level of stress, a high level of technology. How do those things, and the drips, how do all those things play into the liability issues of critical care staff?
Well, I mean, obviously they all do. I mean, alarm fatigue is a big thing in nursing that's, you know, come to light over the last several years. And the ICU, especially, because everything alarms for every different reason, you know, so you have to be able to discern what's an alarm that needs attention immediately, what's an alarm that, okay, you need to go check on, what's just an IV pole beeping that you just need to go. I mean, but even then with the critical care, you need to be on top of the IV pumps as well. But it does, it plays into fatigue and frustration. You're bringing up like nightmares for me with the bells. You know, a lot of intensive care units do something that's called continuous renal replacement therapy. And so that's basically like a 24-hour a day dialysis machine. Mm-hmm. And in my unit, the nurses didn't do regular dialysis, but we did do what's called CRRT. And those machines can alarm it's a really complex system, but one little air bubble in one little tube will have the alarm going off for, you know, sometimes it feels like all day. So it can just increase your frustration, your irritability, you know, make you feel inadequate at times. Mm-hmm. So, But those do play a lot into, just liability and making sure that when an alarm goes off, someone knows, like if I'm covering for someone at lunch and their patient is having low oxygen levels, then, not only do I need to tend to that patient and make sure they're okay, but I also need to make sure that I report off to the nurse when she comes back from lunch. If I've had to do any type of communication with the doctor in that meantime, yeah. So, communication is, it either makes it or breaks it. And when you don't have good communication in an high paced, intense atmosphere like that, things get missed. And so I think that's probably one of our biggest liabilities, is just effectively and thoroughly communicating what's going on. I know on a regular unit, report for the bedside nurse is relatively quick per patient. It may take you the same amount of time to get through report at the beginning of your shift on all of your patients, but each patient is, it's just a brief rundown. And in the ICU, for 2 patients, sometimes report in the morning can take an hour. It's because you just have to go over every little detail. And when you leave out those details, sometimes bad things can happen.
My neighbor across the street about a year ago ended up going into the hospital and being diagnosed with a rare form of bone marrow cancer, which was resolved. But in the meantime, he spent quite a bit of time in ICU. And what I noticed standing there with his wife one day was when the team came down the hall. It was Christmas time. Each one of them had a Santa hat on, which was a little incongruous. And they were rolling a computer. There were 4 of them. And the intensivist was one of them. And they came down like the squad. And they were going room to room to room. And when they got to my neighbor's room, they looked at the nurse. And she was the one who led the update. She went through every single piece. And the intensivist was relying on her to be able to pull all those pieces together. They completely ignored the wife and I. They were focused on her. They were looking at their computers. They were talking and mumbling and then deciding on a revised plan of care. And then the squad moved down to the next room. It was like a dance watching this.
It is. So daily rounds is what we did in my unit. And at 9 o'clock every morning, the team got together, and you're right. It's the intensivist, whatever mid-level providers we have on staff that day, the charge nurse, the unit manager, physical therapy or occupational therapy or speech therapy, if anybody happens to be there, respiratory therapy. So, and it sometimes it could take a couple of hours for them to get all the way around the unit, but you're right. They come to the door, I, as the nurse, would go out. I would run through kind of run down my information. A lot of it, they already know, of course, but updates, anything that's changed. And we would invite our families to participate in the daily rounds. But I always told my families before that happened, like, they're going to talk over you. They're going to talk back and forth about things, and you're not going to understand all of it. But as soon as we're done, I'll come back in and I'll explain everything that we talked about. And so the communication with the family is a big part of it. Mm-hmm. So the daily rounds has really, I think, made a big, big difference in making sure that everyone in the care team is on the same page.
We were talking about the liability issues, and I think you pointed out the communication. And I know that ICUs are filled with titrating drips, precise measurement of doses. Tell us about the risk of medication errors.
Obviously, there is a lot of room for error when you're just dealing with so many different medications that a patient can be on at one time. And I think the two most critical drips that I can think of right off the top of my head is there's heparin drips for people who have had any type of blood clot, a stroke, anything like that. They may be on a heparin drip, which of course puts you at risk for bleeding. So a titration error or a calculation error there could be detrimental in either direction, either bleeding or not preventing a clot from forming if somebody's really high risk. And the other one is insulin. We've got millions of diabetics in this country and the world. A lot of people don't realize that you sometimes need insulin through an IV that's going in at a constant rate for sometimes several days at a time. And insulin is one of those medications that, if you drop a blood sugar too quickly, you're going to damage the patient. You could send them into a diabetic coma. There's all types of things. And I've seen errors in both of those medications before. The insulin requires usually every 1 hour blood sugar checks and then titration of the medication. Luckily, the system has what they hope is a way to mitigate liability by having a second nurse who has to come and sign off on that medication when you give it. If I change the insulin dose here, you would have to come into the room. You would have to see that I have the drip set right. You would have to look at the calculation and verify that that is correct. And then you have to sign off in the computer to verify that everything's correct. So we do have some good protocols in place to try to prevent those types of errors, but they do occur sometimes.
I was doing my annual CEU requirements for my Florida license, and last night reading an article about medication errors and the concept of medical errors in general. And that was one of the examples that the authors of the article gave, was a critical insulin drip that should be checked by two people.
Yes. Always.
Yes.
Yeah. And one of the issues that sometimes happens is a nurse goes in and they change the drip, and then they don't change it in the computer at the time for whatever reason, because 100 different things can happen. And so then they log in to the computer, maybe outside the room, and say, hey, Pat, can you come sign off on my insulin for me? And somebody does, but they don't go in the room and check and make sure that the drip has changed. I've come in on a morning shift, taking over for night shift, where the insulin level hadn't actually changed at all in like 3 hours, but it was documented in the computer that it had been.
Mm-hmm.
So that's 2 nurses, not just one. So those are things that you have to be really, really careful for.
What about the critical care charting? You mentioned that in terms of going into the computer. When I first started reviewing cases for attorneys, critical care flow sheets were 7, 8, 9 pages, and they folded out like a roadmap. And when all of that got put into the computer, you could end up with pages and pages and pages of flow sheets for critical care nursing. And the other thing that I see all the time as I review medical records is a lot of copying and pasting by physicians in progress notes that go on for pages and pages and pages and repeat the same information over and over and over again. How do we, as legal nurse consultants, wade through all of that documentation?
It's so funny. A common theme that an ICU nurse hears is, you only have 2 patients. I mean, how busy can you be?
Oh, yeah, sure.
Well, I mean, there are honestly days where, because my responsibility as a nurse is to take care of that patient. And most of us have what we call our brain. It's a piece of paper that you can design however you want to. We all have our own little personal ways that we like to do it, that we write absolutely everything down on, throughout the shift, because if I don't get to sit down to chart it right then, it's difficulty remembering it. So the charting is ridiculous in the ICU. I mean, it's so much more than what an average floor nurse would even begin to comprehend until you try to sit down and do it. You know, we have to keep track of, there's a lot of things that we have to chart on an hourly basis. You know, vital signs hourly, sometimes a lot more frequent. The patient's intake and output, so the IV pumps, the urine, the JP drains, the chest tubes, the nasogastric tubes, you know, I mean, they've got it coming in or out, all different, all different ways. We have to document, you know, if we're doing the insulin checks, blood sugar checks, we have to I mean, there's a lot of things that require hourly charting. The one nice thing, I worked in the Epic system, so that's the only one that I can speak to. And I know a few years ago, Epic made it so that when I log into my patient's chart for the first time that day, I, as the nurse, can't copy and paste anything from the previous nurse. Once I go in and I chart my assessment, or I chart my, you know, whatever it is, I can then copy and paste it. So it mitigates some of the risk for, you know, has that patient's wound even been looked at in 3 days, because I can't copy and paste from the person before me. Now, it's not that way for physicians. You're right. Physicians are notorious for copying, pasting the history and physical, the course of the progress. And I think they do it in an effort so that if you're a new physician coming in to see this patient for the first time, maybe you don't have to read back through every single note. You can see the whole picture right there. But as legal nurse consultants, it can really be frustrating sometimes. I find that in my practice, I have to kind of get a feel for each physician and the way that they format their notes, because some actually do type out everything new each time, and then some just go down to the very, very bottom of the assessment or the plan or whatever and just type in some notes. And I even had a case recently where a physician was doing that, but they weren't putting in the date for each new piece of information. So there was no way to tell when it had actually occurred. And then you do have to go back through each previous note and try to piece it together. So it can be frustrating trying to decipher what's been copy and pasted, what's actually been done. Yeah.
I know that Medicare a couple of years ago wanted to crack down on this problem and felt that copying and pasting was essentially fraudulent documentation because it wasn't newly entered, it wasn't verified, it was an effort to take shortcuts. I'm not convinced that anyone's practice has changed based on the charting that I have been reviewing recently. So that is a further dilemma in trying to figure out retrospectively, which is what we do as LNCs, what actually happened, what is real, new, current information, or what is a comment that somebody made 5 days ago and it's just been brought forward day after day after day.
Exactly.
So let's focus in the remaining time that we have on the challenges, the special challenges associated with working in a critical care unit. There are legal nurse consultants who will review medical records of people who suffer trauma and end up in ICU. There are medical malpractice cases that end up with a patient who has an incident that leads them to go to ICU, or something bad happens within the ICU unit itself.
Right.
What are some of those challenges of caring for patients in ICU that show up perhaps in medical records? Sometimes they appear in depositions when healthcare providers talk about what happened associated with a critical event. Can you give us a little perspective on that?
As far as how the patient lands in the ICU, like what went wrong, that kind of thing? What do you ask?
I'm thinking about
Sorry.
the atmosphere in the ICU itself. As an example, if I'm as a med-surg nurse annoyed with another worker, I may not see that person again until the end of the shift when he or she is sitting in the nurse's station for a few minutes. In ICU, if you're annoyed with Dr. Jones
Right.
or you're annoyed with Sarah Smith, you can't exactly go anywhere and avoid them. Or the
Right.
tensions, the frustrations, the irritations that build up between people, you can't dissipate them. That's my speculation based on thinking about the ICU and how does that impact some of the liability issues.
Okay, so yes, there are definitely times where we don't all see eye to eye. You're never going to be in any work situation where everybody sees eye to eye. However, the ICU, the nurses that work there and the other ancillary staff that are there and the providers, we depend on each other. So when something like that does happen, at least in my unit, I have had a wonderful unit. Like I've mentioned, I had a wonderful manager who stepped up to helping make sure that we were all getting along. I think cliques do form. You've got these friends and those friends and that type of thing. However, conflict, there's not a place for it in the day-to-day. And I say honestly, in my 10 years of nursing, most of those in the critical care unit, I've really only seen like one flat out fight between a nurse and a nursing assistant. But it makes everybody on edge. It makes everybody more, I don't know. It changes the atmosphere dramatically when there's a riff going on. And it's not good for anybody. It's not good for the patients. It's not good for the staff. One of the things I was going to say earlier too, that I forgot to mention, was that part of the atmosphere in the ICU is we laugh. And some people really find that off-putting or offensive, because here is, you've got your loved one who is really, really sick or possibly dying, and you can hear nurses out at the nursing station just having a grand old time. And it's kind of like you either laugh or you cry or you lose your mind. It's just, there are times when we cry, but we really have to try to keep each other's spirits up. And we do that with humor. And when you have a disagreement or an argument going on within the unit or with a provider, it really does just change that atmosphere. It puts everybody on edge. And, I think when we're worried about what else is going on in the unit like that, you're not focused on your patient, and it just compromises the care.
Is there any parting tip that you would like to share with legal nurse consultants about looking at ICU medical records?
I would have to say, a lot of information comes through on one sheet. You can have vitals and arterial lines, and you can have all kinds of stuff coming in on one sheet, and it might work best. My brain works best when I'm looking kind of at one thing at a time, because if I try to look at everything that's going on one page, it's really easy to get overwhelmed. It's really easy to get distracted. So maybe just picking out one thing to look through first for that date range. That doesn't always sound plausible, but trying to organize the information in a way that makes sense in your brain is, I think, the only way that you can really get through them.
How can our listener find out more about you, Amy, and the services that you offer?
Oh, so my business name is Wake, W-A-K-E, Wake Nurse Consulting. My email address is wakenurseconsulting.com. Website is wakenurseconsulting.com. And on LinkedIn, I also am on LinkedIn, Amy McCutcheon. And yeah, I love working on this side of the medical records. It's really interesting to try to find out what did or didn't happen. And so, yeah, please reach out. That would be great.
And could you give your email address one more time?
Sure. So Amy, AMY, at wakenurseconsulting.com.
Perfect. All right. Thank you so much, Amy. I appreciate you sharing your thoughts on what is probably one of the most challenging aspects of nursing, one of the most challenging settings of nursing, with the high intensity of staff, the high level of technology, the critical nature of dealing with people who are deeply sick and can deteriorate rapidly, the need to work together as a team and communicate well, the importance of laughing and breaking the tension with that Black humor that we love in healthcare, but not everybody else understands.
It's true.
You've brought up some great points that will help us as we look at critical care records.
Well, thank you so much for having me today, Pat. I've really enjoyed it.
Thank you. And if you are a listener or watching this on YouTube, if you would subscribe to our YouTube channel at Legal Nurse Business, that would be great. You would then be notified every time I put up a new video or a new interview. You'll be notified. Leave a comment on this video if you're watching this on YouTube. A thumbs up or a thumbs down, and leave a comment. Tell us what you think. And be sure to come back next week for a new episode of Legal Nurse Podcast. Would you like the best of the best legal nurse consulting podcasts? Before I explain how you can get them, here's a tiny bit of background. I'm Pat Iyer. I started Legal Nurse Podcast in September 2016 to bring you tips, inspiration, and new ideas in a new format. I've written a lot of books and I've taught a lot of courses, but I didn't have a way to reach you through audio. Since 2016, the podcast grew to include guest interviews, a co-host, transcripts, and the video format. When I started the podcast, what I did not expect was the extent of our international audience. My podcast hosting company keeps track of the location of our listeners and the number of downloads. You are part of an international audience. We have listeners in 82 countries. Our top 6 countries are the US, Japan, Canada, Australia, Germany, and the UK. Our podcasts have been downloaded over 102,000 times. And I know which shows are downloaded the most. That brings me to what I want to announce today. Now available is our newest podcast bundle of top shows. Using the data from our hosting company, I created bundles of top podcasts in 6 categories: marketing, client relationships, finance, business development, expertise, and stories of successful LNCs. These bundles are found only on my website at podcast.legalnursebusiness.com. Each bundle has the top 4 shows in that category. When you go to podcast.legalnursebusiness.com, you'll be able to put in your name and your email address and pick the category of bundle that you are interested in listening to. You'll pick that topic and you'll listen to the 4 shows in that bundle. You can pick one or more of the topics. You'll also be able to get the deluxe workbook, which has questions to deepen your knowledge and to help you focus on the key points in each of our shows. The workbook also has the full transcripts to enable you to refer to the knowledge we shared without having to re-listen to the show. There's a small investment for the workbook. Thank you for listening to Legal Nurse Podcast and watching it on our YouTube channel at Legal Nurse Business. Your interest keeps my podcast going and growing. And be sure to go to podcast.legalnursebusiness.com to pick your podcast bundles and workbooks to enhance your knowledge. This is Pat Iyer with Legal Nurse Podcast. Kenyatta Christmas is with me today. She is an acute care nurse practitioner. We've just finished doing a podcast talking about her love, and you can watch your eyes light up when she talks about working in the critical care setting. What are some of the key topics that we covered in your podcast, Kenyatta?
Well, Pat, we touched the surface on medications and how critically ill these patients are, and careful titrations of these medications. And with improper usage, you can have some serious outcomes. We also talked about the role between the NP and the physician in the critical care setting. And then we also talked about how rapid response teams and code teams are integrated within the critical care setting.
As you can see, there was a lot to talk about. Kenyatta is well-versed in this area, and you're going to want to be able to catch her podcast and find out what she has to say about being a critical care nurse practitioner, a role that will help you as you're reviewing cases and you come across nurse practitioners who are documenting in the medical record and managing care. You might be surprised, like I was, at the expansive scope of practice, and Kenyatta spells that out well in her podcast. Be sure to catch Kenyatta Christmas's podcast.